Welcome everyone. I'm Andrew Wright. I'm a professor at the University of Washington, and I'm going to be hosting along with Dave So, who's with us, who's one of our R4 residents. Actually, R5 residents now, since it's
hard to
the
believe.
new year. Amazing. So Dr. So will be co-hosting, and we're joined by a few of our other residents. And why don't we see, let's see, we've got about 40 people on the call right now. Let's give just another minute or two before we get started, and then we can launch into the afternoon session. I'm watching the numbers of participants tick up, so we'll give just another minute or two here.
You should consider some background music or something. I guess we're all going to like learn a lot this year.
There was actually a really great documentary on KUOW this afternoon. I was driving from the U to Northwest and heard it on Northwest Hip Hop. It was fantastic. So if anyone on the line wants to learn more about Northwest Hip Hop, they are releasing it as a podcast called The Record. So really good.
So, Dr. Wright, I want to know more about Northwest Hip Hop, and I was going to be suggesting hip hop for the background music that Dr. Horvath was calling for. That's my operating room music.
We got, Sir Mix-a-Lot, obviously, and all the way up through Blue Scholars, and now Macklemore.
I'll have to curate
a thriving hip hop scene. Sorry, what was that, Joanna?
Sure, I'll have to curate a playlist for next week or for the next one.
Well, I tell you what, let's, I don't want to wait too long before we get started because there's a lot to cover in an hour. So for the folks that have joined in the last couple of minutes, I'm Andrew Wright. I do primarily minimally invasive surgery and then also heavily involved in surgical education at the University of Washington. I'm going to be your host along with Dave So, who's one of our R5 residents. Bunch of wave, there he goes. He'll be co-hosting with me. We've got Karen Horvath, who's our program director, and Doug Wood, our chairman. And then we've got David Droullard and Nina Clark. So David Droullard is one of our research residents, and Nina is, you're an R2, correct, Nina?
That's right, yep.
Perfect. So this is the first of our virtual visits. We're planning on doing a virtual visit every 2 weeks through the next couple months during the application process. This is going to be the most formal of the virtual visits because this is sort of the overview. So Dr. Horvath has prepared a slides just to give sort of an overview of the program at a very high level. Each of us on the panel is going to take a little section of that, and then we'll have plenty of time to talk and have some discussion and question and answer among the panelists. We had a number of questions that were already submitted to us, but as we go, if you have more questions, you can type some questions into the chat, and then I'll try to moderate those questions towards the end. So as I mentioned, this is going to be the most slide heavy of these virtual visits. Even at that, we're going to spend less than half of our time looking at slides. In 2 weeks, we're going to have another virtual visit that will be entirely just a discussion with the residents. The faculty, none of the faculty will be on. So if folks have questions they don't feel comfortable asking with Dr. Horvath or myself or Dr. Wood on the line, the residents will be able to talk to you at that session. And then future sessions, we'll talk about things like resident life, the different rotations at the different hospitals. We'll have a session on diversity and on wellness. So we really have, I think, a rich set of virtual visits scheduled for the next little bit here. So with that said, let's go ahead and launch in. So I'm going to share my screen here if I can. Perfect. So as I mentioned, I already gave an introduction into our panelists. So I'll introduce my co-host, Dr. So he grew up in California, product of Harvard and Michigan. He most recently actually rotated on my service as an R4, and he's now on our acute care surgery service. And he's actually on call right now. So if he gets called to do a case, he may have to leave us early. But very, very excited to note that Dave matched just recently for surgical oncology at MD Anderson, which is really one of the two premier surg-onc programs in the entire country. So very, very proud of that for Dave. So
thank you very much, Dr. Wright, for the introduction. And I'll be introducing each of the speakers today, so who will also be discussing some of the aspects of the agenda that you see here. I just wanted to say a quick thank you to everyone for joining us. For those of you brave enough to keep the camera on, also a big plus. I can tell you personally, having gone through this fellowship application process, starting in March of this past year, when everything suddenly went virtual, I can certainly sympathize with being faced with the prospect of making a hugely important decision without really having met the people or seen the place in person. And this series is just a part of our effort to make sure that you can get that same sense of community and the warmth of culture that all of us residents here felt on our own interview days, and sort of led us to the decision of choosing University of Washington. In that vein, I'll be introducing each of the speakers, but also we'll be focusing more on sort of where they come from and where they've trained and spent their lives prior to coming to the Pacific Northwest. If we needed to run through the CV of Drs. Wright, Wood, and Horvath, we'd be here all day. So I'm not going to really focus on that aspect as much. Our first speaker is, of course, our program director, Dr. Karen Horvath. She has been our program director and has been really a cornerstone of our residency program for many years. But originally, she hails from the East Coast and grew up in Pennsylvania, after which she went to Bucknell and New York Medical College for her undergraduate and graduate training. And then she completed her residency staying in New York at Columbia prior to starting her position in Seattle. She's on our acute care surgery team, and she has a particular world-renowned expertise in necrotizing pancreatitis as well. So Dr. Horvath.
Thank you very much, Dave. I appreciate it. So I'd like to, for those of you who have been to the Pacific Northwest, you know that it really does look like this. And for people like those of you like me, I was a Northeast to Northwest transplant many, many years ago. And I've fallen in love with the Pacific Northwest, and I say there's a reason why that it's called the Great Northwest. It really is. It's an amazing place to live. Just there's beautiful scenery everywhere you go and everywhere you look, but there's also a wonderful sort of cultural beauty to the people and the collegiality of the people. So next slide. So one of the hallmarks of training at University of Washington is the WWAMI region, and you'll hear and read a lot about the WWAMI region, which is for the 5 states of Washington, Wyoming, Alaska, Montana, and Idaho. Basically 27% of the land mass of the United States, and 35% of the people live in rural areas. And with this is our catchment area for patients, and we're the only level 1 trauma center and University Hospital in this 5-state region. And unlike many of our competitor training programs, I guess you would say, that live most commonly in geographically dense areas of the country, when you have a lot of kind of tertiary referral centers competing for the same high acuity cases, this is not something that we have a problem with. So we get sent incredible pathology from all of this 5-state areas, and it makes for an incredibly robust and rich clinical and operative surgical experience that really, I think, is really unparalleled anywhere in the country. Next slide. Our department has 118 faculty members. We have residents from all over the United States, and we really don't discriminate north, south, east, west, Midwest. We take people from everywhere. As most of you know who signed up for this this session today, we are one of the top academic surgical training programs in the country, and we're very proud of that. One of the top funded public research institutions and NIH funded departments of surgery in the country. We have several Nobel laureates who call University of Washington their home. And so but I know that to people who, those of you who are looking at, again, similar programs that can kind of have similar boasts, one of the things that I often get asked is, how are we unique? And I think one of the ways that we're unique is we have a very special culture of collegiality and collaboration that exists within this robust intellectual framework that I really, I've been many places around the country. It's really something very, very unique and special. It's what drew me to the University of Washington from the East Coast many years ago, and it's really the thing that's kept me here. I think it's a very real thing. Next slide. I think one of the other things that we're very proud of are our faculty. We have very highly sought after faculty from around the country. They work very hard to get to the University of Washington, and we have a very low turnover. So when they come, they stay. Many of our faculty in all specialty and subspecialty areas kind of represent the who's who in American surgery. They're leaders both in research and their different committees. And these are the people that you are learning from in the operating room, you're doing research with, and you're working with side by side every day. You're going to their homes and really getting to become part of the family community. One of the things that we have really tried to focus on, starting with the 2003, when we first came out with the duty hours in 2003, and there have just been a number of challenges that graduate medical and surgical education has given us over the years. And oftentimes that leads to, say, fewer hours to work or more to do. And our goal, really, my philosophy as program director, has really not been to maintain the same level of surgical education, giving fewer hours or more challenges, but to continue to improve the experience, improve the educational product that we train. And I'm very proud that we have been able to do that. These are some of the changes here. I don't know if you can see my arrow, but these are some of the things that we've done, and many of the things that we published on. We've been very successful, and I've been very pleased that we've been able to accomplish our goals. I'm a very mission-driven program director. I think that as I've gotten older, I think I've realized more and more how important a mission is, because it's really in a very complex world when there are many competing priorities, knowing where you're going and where you're headed is the thing that kind of rights you and keeps you from going in circles, essentially. Our mission is to train leaders in surgery and to train physicians who can operate in a community environment that holds to the highest ethical and professional standards and espouses the core values of duty, honor, and responsibility to patients. So this is our program mission. The way that we achieve this is through a comprehensive and very focused clinical experience. And we'll talk a little bit more about the focused aspect of training at the University of Washington, kind of at different places along the slides. We definitely provide graduated responsibility from day one. And one of the things that I also will expound on a little bit more is the philosophy of training junior surgeon to independent surgeon. This is our philosophy. Next slide. And what I mean by that is, I think that, you know, when in the as we're now into 20 years into the 21st century, and I was the program director in 2000, and really asked myself, you know, what is 21st century training going to look like? How is it going to differ than 20th century training? And of course, I was a product of 20th century training. I think that one of the things that I would say that the big philosophical thought in the 20th century was that people would come in as residents, and in 5 years we would train them to become a surgeon. And so, you know, in 5 years we're going to train you to become a surgeon. I think that in the 21st century we've evolved to, we don't train you to become a surgeon in 5 years. You are a junior surgeon from day one that you arrive with us. And our job is to train you to become an independent surgeon. And that's independent, day one of leaving UW without any additional training. If you don't, if that's kind of the direction that you're going. Part of our other cultural MO that we have in the in terms of 21st century is really we really work to flatten hierarchies. I think that that's one of the beautiful cultural aspects of the Pacific Northwest are the flattened hierarchies, and I think that we are the perfect ones to lead that change in surgery. And we've been working at this for for the last several years, and I think we've made some great progress on it. I'm very proud of that. We also have one of the other things I think that we're leaders in the country is kind of in surgical professionalism, or is values of mutual respect, which are very prominent in the Pacific Northwest. Again, more so than in many other places that I've been in a very unique and special way. And I think that I put a picture of Dr. Davidson's photo here. So Dr. Gianna Davidson is my section chief, and she actually is the assistant dean of professionalism. So to have a surgeon as the assistant dean of professionalism for the School of Medicine, I think is a really important statement. And next slide. I think that resident mentorship is a very important, and very important thing too, that I think we do very well. We are very fortunate to match some of the brightest and most talented applicants like yourselves from across the United States. And we really are interested in a very, very diverse class in all ways. So diversity in goals as much as diversity in other ways. And our commitment to our residents is to identify our residents' individual strengths, and really we want to help each resident to meet their goals, whether that is becoming a rural surgeon or becoming a future chairman of a major U.S. department, whether it's matching MD Anderson in surgical oncology like Dave did, or whatever. But basically to help maximize each of our residents' personal and professional goals. We do so so you will have a faculty mentor as well as a resident mentor, kind of from day one coming into the program. A little bit about community development, and we're going to expand on this a little bit more in our focused virtual visit in this area. But we have ways that residents get together. We try to bring a lot of the journal club and things like that out of restaurants and our university gathering rooms, but into faculty homes, so we can spend time together and build our community. And we do that also with the department. So lots of ways that we are constantly working at building our community and the family sense that's so important to us in our program. And just kind of a spot on resident leadership, again, something that we expand on elsewhere, but a lot of ways that we meet together, residents and they, with Dr. Wood, with the program director. We have the Resident Engagement and Change Committee, which really are resident leaders that help to kind of drive change forward in our program. And we also provide many opportunities to get our residents into national leadership positions. And these are just kind of some examples of where our residents have been in leadership positions over the years, kind of nationally. Okay, and with that, I think that we're ready for you. Back to you, Dave.
Thank you, Dr. Horvath. Next, I'll be introducing Dr. Doug Wood. He is the chair of our Department of Surgery and, again, needs very little introduction. His world-renowned expertise in thoracic surgery and oncology have led him to innumerable leadership positions across the nation and the globe, including being the chair of the NCCN Lung Cancer Screening Panel. But long before he was securing Medicare coverage for lung cancer screening with low-dose CTs across the nation, he hailed from Michigan and went to a small school in Boston for his undergrad and medical school training at Harvard, and finished his residency at MGH, but then again came out into the Pacific Northwest and has been with us and has been a solid foundation for our residency and our general surgery program overall. So Dr. Wood.
Oh, you're muted.
I'm actually best when I'm muted. Most like to have control of the mute when I'm in a Zoom meeting so that they can mute me, but thank you for telling me, Dr. Horvath. Thank you for the introduction, Dave. And I'm going to be very brief because following me are Drs. Clark and Droullard, and I really want you to have a chance to hear from our residents. I think they're more important than hearing from me. But I do want to emphasize our important commitment to equity, diversity, and inclusion. And of course, that's a very broad area. It's also an extremely important area that I would say at baseline, surgery is not very good at. And that I would also say the University of Washington, maybe because of also being in the Pacific Northwest, is not been at the forefront of being the most diverse departments. And we notice that, and we want to be better. And this has been a commitment that we've made across the department, the total community of the department that includes not just the faculty, but also our residents, fellows, and our staff. And we are making improvements, but I'll be honest, I do not think we are yet where we need to be. Our general surgery program is half women, and with close to a third of underrepresented minorities. I also look at our total department, which includes our other integrated residencies in plastic surgery, vascular surgery, and cardiothoracic surgery. And then we also have 12 fellowships across the spectrum of training. And diversity requires many things in terms of being committed to recruitment, commitment to then support, promotion, career development, advancement, and helping individuals grow and attain leadership positions within surgery, first as residents and then as faculty. But it's also things that are sometimes seemingly superficial, but sometimes superficial is also important. And this slide shows you pictures from the hallway right outside my door, the hallway of the Department of Surgery. And I've emphasized this because a couple of years ago, and when I took over as department chair, our hallway had all the graduates, all the chief resident graduates from our beginnings in the 1950s. And as you can imagine, they were virtually all white men. And actually, the more recent 20 years have been substantially different than that, but we didn't have room to hang those photos. So we only had the early years of all white men photographs in our hallway, which is in one sense superficial, but in another sense shows those who walk our hallways, this is who we are. But that's not who we are, nor who we aspire to be. And these are paintings that one of our nurses at Harborview did of some of our residents. And we bought all of those paintings. They're now in the hallway that represent the diversity of our residents. And we now have all of our graduating chief residents, which is much more diverse, so that our hallway looks more like what we want for ourselves, although we are still working to improve. Next slide. Our Department of Surgery has a diversity council that really helps advise me and the department on aspects that are important for diversity, equity, and inclusion. We have institutional membership in the Society of Black Academic Surgeons, as well as the Association of Women Surgeons. We send residents and fellows and faculty to each of those meetings. We've actually created diversity as a part of our mission statement for the Department of Surgery, and have also included involvement in diversity as a part of our criteria for promotion. We're working on developing a Department of Surgery anti-racism book club. And actually Dr. Wright is one of the individuals leading that. We were just having a meeting about that. Our faculty have been major leaders in the Black Lives Matter issues that have gone on in the past weeks and months, and demonstrations within Seattle and leadership within Seattle of how our community, as well as our institution, adopts anti-racism policies and improves how we support a diverse community. One of our faculty is also the leader of a Doctor for a Day program, which helps bring underrepresented students at the middle school and high school level into exposure with faculty and residents within the department, so they have some exposure to the potential of careers in medicine. And then the poster there is a new initiative that's a collaborative between the Department of Surgery here at the University of Washington, that includes also UCSF and Oregon Health Sciences, where we're working together in a collaboration in a mentorship program for underrepresented minorities in surgery for our residents, fellows, and students. And I put this up here because many of you might be interested in this program on August 12th, 5 to 6:30 Pacific time, a way to get some additional information. And our DIO actually forwarded another opportunity that I'll tell you about, which is our Network for Underrepresented Residents and Fellows. And they are hosting a diversity recruitment open house, and that's for all GME programs at the University of Washington. And that's August 26th from 6:30 to 8 Pacific time. Sorry for those of you on the East Coast. Next slide. And we've also developed a women's council that helps advise me on policies and issues that can support recruitment, retention, and promotion of women in the Department of Surgery as residents, as students, and as faculty. We have a resident group and now a medical student group as well. And then I'll finish just with a point about wellness, which I think across all departments of surgery, this is an important topic, recognizing the huge impact of burnout on our residents and faculty. This is an initiative that, like most of our initiatives we embrace as a whole community within the Department of Surgery. That is, I do not think that these things are limited to faculty or limited to residents. It includes our staff, the people that we work with, that we work beside every day, that actually are a major part of our Department of Surgery community and support us to fulfill our mission. We're becoming involved in a mindfulness program that is centered from UCSF to develop stress resilience for our residents and ultimately for our faculty, but that's being focused on the residents. And our involvement in the second trial, which is a whole national trial on improved environment and culture within surgical training. So I welcome all of you to consider us in the Pacific Northwest. Glad that we can have a session like this, but I do want to turn things over to our residents who can give you more information about the program.
All right, thank you so much again, Dr. Wood. Next is Dr. Nina Clark. She is one of our recent R2s, having finished her intern year in style. She hails from Michigan, but went to Cornell for undergrad and then flew across the country for medical school at UCSF, and then came up the coast to join us last year. She has a particular interest in hepatobiliary surgery and will be talking to us a little bit about the hospitals in our system and case volumes.
Hi, everybody. Thanks, Dave, for that introduction. I like to think I finished my intern year in style, too. So I think Dr. Horvath touched a little bit on this, this idea of focused clinical experiences that we get here at UW. And actually, I was excited to get to talk about this topic in particular, because it's one of the things that really drew me to the program here. I did medical school at UCSF, which I think has a relatively similar setup where they have several hospitals where you get kind of a wide breadth of experience. And I found that to be one of the really big strengths of the UW program as well. One of the highlights that we try to emphasize to you folks, that's true, we do have a lot of Michigan representation today, go blue, is our experience at Harborview Medical Center. It's one of the big trauma centers in the United States. We serve pretty much the entire WWAMI region, which you'll hear a lot about. The more you hear about University of Washington, the more you'll hear about WWAMI, because we are pretty closely tied to our big surrounding area and community that we serve. Harborview is really where I think a lot of us residents feel like we truly become surgeons. It's where we get a lot of our trauma, all of our trauma experience. We rotate there at various levels every single year of residency in various roles. And so it's really nice to get kind of the breadth of trauma experience there. As interns, we do night float. We take care of floor patients. As R2s, we run the trauma bays in the emergency department. And then as we go up in years, we work in the burn surgery service and the trauma services at various levels. And so it really is one of the special parts of this program and one of the special parts of our training. And then, in addition to that, we have our other hospitals. I think we can flip to the next slide that goes through those. So in addition to Harborview, where we spend a lot of time in all of our years, we also have these other places that are kind of peppered into our training that sort of supplement with different things. So UW at Montlake is kind of our other main hospital where we spend quite a bit of time as well. It's one of the major cancer centers. It's a big referral center. We spend time in a lot of our general surgery services at University of Washington at Montlake. But in addition to that, we've got community hospitals where we rotate at. We've got a children's hospital, Seattle Children's, which is one of the best in the world. We spend time at the Seattle Cancer Care Alliance. Many of our outpatient clinics, particularly for surgical oncology, of various flavors, happen at the SCCA. So we spend time at pretty much the breadth of clinical general surgery. We see the big referral centers. We also see community surgery. We have a VA, we have a children's hospital, we have the big trauma center. So I think it's one of the huge strengths of our program, and one of the things that makes it really exciting to get to train here and spend time here is you get to see those flavors and see what kind of speaks to you, so to speak, in terms of what kind of surgeon you want to grow up to be. And then at each of those different locations, we have what we realized yesterday, a female program associate program director. And so these folks really serve as our primary points of contact for not just kind of crafting our rotations, but serving as mentors for us as we rotate through these various hospitals. They're sort of a built-in mentor for many of us over the years. And I can speak from personal experience, having worked with Drs. Marquardt, McIntyre, Smith, and Zerns personally so far, and I'm headed to Northwest next month to work with Dr. Peterson. All of them are pretty heavily involved in our training, and they like to, meet with residents throughout their rotations, talk to us, and get our feedback on how things are going. So they've been a really a great part of my own experience at many of these hospitals. So it's nice to have somebody there with you as you do these rotations to kind of keep an eye on things and help troubleshoot and make sure that you get the clinical experience that you want from each hospital. And then this slide is kind of about our operative case volume. It's a common question. It's a question I had a lot on the interview trail. We don't have trouble reaching our numbers here, which is great. I've been pleasantly surprised as in R1. I actually just caught up on my case logs today, and so I was able to check in on how I was doing it. I'm going to vastly overcome the 250 case requirement for the junior cases, so I'm well on track to have that beat by the end of this year. And then in addition to that, being the big gig in town for surgical oncology, for trauma, you get a lot of the really interesting cases. You get the bread and butter stuff, but it's often bread and butter stuff in very sick patients who have interesting medical comorbidities, and it makes everything a little bit more challenging, a little bit more complex, and in my opinion, a lot more interesting. And so I think that really speaks to the training that we get. And then the last point here is about autonomy. I'll say that I've also been really pleasantly surprised at the level of autonomy, even as a junior resident, that I've been given and that I've seen folks in my program get. Chief residents run most of our services. I think honestly all of the services that I've been on for the most part are run by either chiefs or even R3s and R4s. You start to get some experience at various hospitals and various services being the true leader and having junior residents report to you. So early on, honestly, you end up in that role where you can be the leader of the ship, so to speak. And then, in addition to that, as a junior resident, I've had a gradation and a level of autonomy that I think is appropriate to my level. And, I think one of the really nice things about this kind of culture that Dr. Horvath and Dr. Wood have both touched on, this collegiality culture, is that you get to know folks really well. And when folks know you well, they learn to trust you at your level, and they give you more autonomy. And I think that's a really, it's kind of hard to, it's not tangible, so to speak, but it's been really important to me as a trainee here, and really beneficial, I think, to my training. And then also, I think to just touch on this because it's important and timely, our response to COVID-19, and I know this is probably on all of y'all's mind because you are here on Zoom instead of planning to fly out here later this winter. We were really one of the first places that had to respond to COVID-19 early in the pandemic, and as things started to spread and take shape in the country, Seattle was really at the forefront of a lot of that. And the University of Washington was really at the forefront of much of it as well. We sort of have served as the leaders and the experts, so to speak, in this problem since it started. And I think, one of the other intangible things about this program that I really want to emphasize today for you guys is that this is a program that lets you speak up and that responds to residents speaking up. And a good example of that, I think, is one of our chief residents last year, Dr. Nassar, helped us with the emergency response of the general surgery program to the COVID pandemic. He actually got published in JAMA Surgery and got like a local newspaper podcast kind of thing about him. It was ridiculous. But I think it speaks to the fact that, we as residents are able to be leaders a system-based level and speak up and say, hey, we should respond to this. This is how I think we should do it. And we have a willing ear in Drs. Wood and Dr. Horvath, who help us, figure out how to make that happen. And so we've had, initially in the pandemic, when it was, so to speak, our peak times in early spring, we restructured. We had residents at various services getting deployed to help out in the ICUs and in the emergency departments as we were needed. And as things have sort of calmed down again, we have now returned to our normal level of function, but with a lot of changes that are ongoing at the system level in the hospital. And, we have never had problems with PPE. We have had a lot of good work, I think, from the university in terms of developing rapid tests that we can send out for our patients and for ourselves if we have ever needed it. And I think because of those high-level management decisions that have been made with residents in mind and with resident input, we've avoided a lot of the problems that I've seen my friends and colleagues who are at different institutions across the country facing. And then we have the good news that is our operative volumes have returned and bounced back in a big way. We're back to our pre-COVID. Apparently, Dr. Wright informed us yesterday we're actually operating above our pre-COVID numbers now. So that is returned.
All right. Thank you, Dr. Clark. Next is Dr. David Droullard. He is one of our research residents after having completed his third year of clinical training. And has been in the lab for the past year, hence the warm glow in his disposition and the bronze tan from all the outcomes research he's doing at the top of some local mountains. He hails from the land of the Gophers in Minnesota and went to the slightly lesser well-known U of M for undergrad, and then did his medical school training at Columbia. Dr. Droullard, take it away.
Hey everybody. So I'm going to be talking about the two different track programs that we have here and spending a little bit of time talking about the research experience. You guys will note that the University of Washington is fairly unique within the top tier of academic programs because while it offers protected research time for some of our residents, it doesn't require it for everybody. So as you'll see, we have two different tracks that are listed as separate programs in the NRMP, to which you'll match to either the 5-year or the 7-year track. And you're welcome and encouraged to rank both. In fact, that's what I did, number 1 and number 2, and I'm happy to discuss my experience with that process with anyone who's interested at a later time. But of our 7 incoming residents, 4 will match the research 7-year track and 3 to the 5-year track. Yeah, next slide, please. The reason for this is at UW, we recognize that the 7-year model doesn't necessarily work for everyone, given the diversity of their career goals and interests and experiences. For example, there are many people who already have a mature research career under their belt before starting residency and don't really need that additional 2 years of professional development. Or maybe they have specific plans to do that work after residency and closer in time to their first faculty appointment. We also recognize that many people who are planning to be community surgeons still want all the benefits of training at a top academic program, with the patient complexity, the diverse clinical experience, and the emphasis on evidence-based practice that happens in a program like ours. And this is particularly relevant to our mission to serve the 5-state WWAMI region, for which, as has already been mentioned, we're the only university surgery program. And just as an example of that, one of my chief residents from when I was an intern, Dr. Bijaba Garrison, is practicing up in Alaska now, straight out of surgical residency. Of note, matching to the 5-year track doesn't keep you from doing research while you're here, and it definitely does not keep you from matching to a top fellowship, as you'll see in some subsequent slides. Next slide, please. If you do match to the 7-year program like me, you will enter the 2 years of research after your R3 year. We have a very broad range of research opportunities here that we'll go into more detail in a coming session, depending on your clinical and your research interests. But for the purposes of this talk, I'll just mention that we have access to robust extramural and intramural funding sources. Of note, we have multiple NIH T32 fellowships available. which essentially provide funding for your research work, your salary, and as well as an advanced degree. For example, I'm doing a Master's of Science in Health Services Research through the UW School of Public Health. We also have a robust program of research mentorship starting early. It starts with a summer welcome barbecue that's hosted by Dr. Flum and Dr. O'Keefe, pictured here, for all the residents that have matched to the research track. And while it's nice to know what you want to do ahead of time, you don't have to worry about having a specific path or experience picked out. If you're anything like me, the first couple of years of residency is really focused on figuring out what you want to do. Next slide, please. So the University of Washington is a leader in global health, both within the School of Medicine and the School of Public Health. And our Department of Surgery is no exception to that. As you can see, we have 3 surgical faculty that are affiliated with the World Health Organization. We also have an established 2-year global surgery research track that's funded by the NIH Fogarty Fellowship Program. And this track can accommodate whether you match to the 5-year program or the 7-year program. And I'll turn it back to you, Dave.
All right. Thank you, Dr. Droullard. And last but not least, I'll introduce Dr. Andrew Wright. As he introduced himself in the beginning, he's a professor of surgery here, as well as the director of the Minimally Invasive Surgery Fellowship and the director of the Resident Technical Skills Education. He initially hails from Kentucky, which I believe is where that bow tie comes from. But he has moved around quite a lot, having gone to Williams for undergrad and then Louisville for medical school, followed by completing residency again in the Midwest in the University of Wisconsin. His practice focuses around Horvath disease as well as complex hernia repairs. For us, he's most well known for his education and for being I think his Twitter account has just over 3,000 followers. And I believe it's followed by
I think Dave got taken over by the Transformers there, so I apologize. We're running a little bit longer than I wanted with the slides because I do want to make sure we have time to get to some discussion. So I'm going to breeze through this really fast. But I just want to highlight the fact that the UW has really put a focus on education and making sure that residency isn't just about service. It really is about education. That goes everything from our weekly Wednesday morning curricula. We have 4 hours every Wednesday that's dedicated to education. We really focus on this, and I'm really proud. My junior partner at Northwest Hospital, Nick Citrullo, was recently appointed to be really director of the ABSITE and the boards and making sure that our residents are well prepared. A lot of our residents do get involved in our health policy. As Dr. Droullard mentioned, he's interested in health policy and in our safety and quality initiatives. So our residents are involved. There's a house staff safety and quality committee. They're involved in NISQIT projects. We have a statewide surgical care and outcomes assessment program called SCOPE. And our residents can actually get a certificate in patient quality from the Institute for Healthcare Improvement. I spend a lot of my time down in WISH. WISH is our simulation center. So the WWAMI, the WWAMI Region Institute for Simulation in Healthcare. I think a lot of programs, especially a lot of good programs, have a simulation center, but if you ask residents how often they actually go to that simulation center, it may be pretty limited. We really try to integrate simulation through the entire 5 years of residency. That includes the Wednesday morning skills sessions. It includes, in fact, a dedicated rotation. So at every level, our residents have an EVATS rotation. On the EVATS rotation, it's they take a vacation week, but then they also have time in our sim lab and a formal dedicated skills curriculum. I think we're really unique. We're the only program that I know of in the country that has a dedicated skills rotation like that. WISH does the virtual OR. It has team-based training. And Dr. Park is one of my colleagues who's really a pioneer in robotic hepatobiliary surgery, and he leads our robotic training platform. And our residents can get their robotic certification. So like I said, I breezed through that super fast, but I wanted to make sure we have time for questions. I think Dr. Horvath has just a couple of summary slides she's going to talk about, and then we'll jump into a panel discussion.
Yes, thank you very much, Andy. So I have a lot, just 3 more slides. I think one of the important questions I often get asked is in terms of outcome. 90% of our residents end up doing fellowships, and they're leaders in those fellowships. But for the 10% that directly enter practice, they're very comfortable doing so without any further training, and so we're very proud of that. This is a very, I'm actually just going to say that you can find what you're interested in here. But these are the programs up to date that for our residents who have matched around the country, and they're top fellowship programs. And there's usually our residents will get their first or second choices when they're looking for their fellowship. And I know, some of the, the very best fellowship programs I know are listed here, and many of our residents, and we just multiple times, through the years, they've matched in these positions. So in summary, I think that our program is prospering, and we work very hard to help it get better and better all the time. When I say we meaning the leadership and the residents working together. We have superb leadership with Dr. Wood, and a very strong focus in resident education by all the faculty. The faculty are leaders in their subspecialty fields, and we have a very special Northwest kind of collegial and collaborative environment that's absolutely not malignant or dehumanizing. And we have, I think that with our new focus on wellness, again, as Dr. Wood said, not only for residents, but for faculty, residents, and staff, as in our entire department community. And we do support research for anyone who wishes to do it. We provide comprehensive preparation in all areas of surgery with no areas of deficiency, and our graduates are prepared to enter practice directly or the fellowship of their choice. And hope you've seen, we absolutely have some of the most beautiful scenery in all the world. So even if you don't come out for residency, you've got to put this on your short list to visit, because it's worth it. Thank you.
Great, thanks everyone. And I think both Dr. Wood and I in the last couple of days have tweeted out some of our favorite pictures of the region. I have to say, it really is the prettiest area of the country I've ever been in. In addition to all of those fantastic pictures of the mountains and the lakes and the San Juan Islands, the city of Seattle itself is fantastic. I don't think we had many pictures of the city of Seattle, but the restaurant scene, the theater scene, music, it's just fantastic living here. On my own personal note, I came out here to do a one-year fellowship and was fully planning on moving back to the Midwest. I had no interest in coming to the West Coast. And after about 3 months here, I started trying to figure out if there was a way I could stick around. And I've been here now for 15 years. So I can't say enough good things about the city of Seattle in addition to the UW. So we got a lot of questions submitted online before the session. So we've taken those, and I'm going to ask a few of those. But if folks have additional questions, feel free to type some questions in the chat. I want to start by talking to our residents. So maybe Dr. So, I'll start with you. When you were looking at programs, what is it about UW General Surgery that really grabbed you when you were interviewing, and why is it that you matched here? And then has that come true, and are there things that you found after you got here that you weren't expecting?
Yeah. So in thinking back, it seems like a lifetime ago, about 6 or 7 years ago, when I was going through this process in a slightly different climate, I remember coming away from the interview day just feeling something that I didn't feel at many other places, many of the other sort of academic places that I'm sure everyone here is looking at. And that is that kind of sense of community and culture that is, again, so apparent, or maybe more easily apparent when you're here and visiting with us and seeing how the residents interact with each other and seeing how the residents interact with the faculty. It's easier to, I think, put all those things on a PowerPoint and tell you that we have this great relationship, but part of this series, again, is to try to show you what the way that I felt. And I felt that kind of camaraderie was really important in the training environment that I wanted. And that was a big reason, in addition to having the world expertise in surgical oncology, which I was particularly interested in, as well as having the opportunity to train at various centers. I think coming from a place like University of Michigan, where there's one big academic university hospital, a smaller VA, but not much else, we didn't get that any kind of exposure to the experience of a trauma center or county hospital, a functionally county hospital like Harborview, or even some of the community-based hospitals that we have here. And the plethora of experiences and the wide breadth of them also kind of was one of the big attractants. And after 6 years of being here, I will say that all of those things that I thought definitely were true and beyond. I think the experience clinically has been more sort of fulfilling and educational than I could have imagined. And I think the variety and the breadth is a real true strength of the program. And this gets to one of our sort of other questions about how much autonomy are we given throughout the years. And I think part of the reason that we are able to get so much sort of autonomy balanced with proper supervision is because the variety of different sites offer very different experiences, where residents at the community hospitals can really take ownership and lead the operation of a bread and butter surgery like appendectomies and start to get really familiar with choles and things like that. And at the places like the trauma hospital, the sort of volume and severity of cases often dictate how much you're actually asked or required to do. And, you know, you automatically get a little bit of a graduation in terms of the autonomy. While at the same time having exposure to the complex cases at university.
Dr. Clark or Dr. Droullard, either of you want to expand on those things or your thoughts?
It's hard to build on that. That was pretty comprehensive. I would really echo what he's saying. I think the diversity of the training sites here is one of our big strengths. Not only the differences in pathology you see, but the different practice patterns that you see. I think it's really a strength for you as a surgeon coming out of residency to have seen a lot of different ways to do something, and to be able to really both have those options when you're faced with a tough situation, but also know what your preference is and your style and how you want to do things. And then I think for me, a big draw was the culture, the community. I wanted to be somewhere where I thought I'd be happy and like my co-residents and colleagues. And then finally the place. I mean, as everyone raves about here, it's really the most beautiful place in the country. And I wouldn't discount that in terms of your quality of life for 5 to 7 years. What you get to do outside of the hospital is pretty important.
So just as a evidence of the dedication of our chairman to surgical education and the culture of the department, he just privately messaged to ask if we could go long, since there's some great questions. And for a chairman to ask for a meeting to go beyond time, that's actually pretty rare. So thanks, Dr. Wood, for volunteering to stick around. We had a couple of questions both beforehand and then also in the chat. Dr. Horvath, how much does the regional time matter? What about folks who might be coming from elsewhere in the country or who don't have ties to the Pacific Northwest?
It's a great question. I think we recruit from everywhere. I know that there are some programs that seem to like people from different regions, like kind of their own region. It doesn't. We've had residents from Mississippi, from everywhere. I say Mississippi because Mississippi, everywhere around the country, and it doesn't really matter where you're coming from. We're just as interested in you. And I think that, again, hopefully we've shown you that making the transition from different parts of the country, even if you've never been here before, to the Northwest is an easy transition. And in fact, actually, most people want to stay once they've been here.
Well, and just jumping in, that's why I wanted to point out you don't have to be from the Midwest to come to UW. Just so happens that Dr. Clark and I are both from Michigan, that Dr. Drouillard's from Minnesota. But Dave, CO, you're from California, so you're a legitimate West Coaster.
Dr. Wood, if I could get you, this has been a really remarkable time the last few months in this country. What's your perspective as the chair on our department's response, both to Black Lives Matter and then also to COVID? I know it's a huge topics, but.
Yeah. So since I asked if we can go over time, can we go over time by a couple of hours?
Yeah.
So I guess let me address the racism aspect, because I think, obviously that's in the middle of COVID, which is impacting all of us, but so is the impact, or I guess the slap in the face that makes more of us pay attention to the structural problems that exist within our society, within our institutions, within ourselves, that's deeply embedded and is problematic in how our communities and how our institutions work. I'm learning every day, and the struggle for me is recognizing, my own faults and the places that I have lapses in my own perceptions. And we've dug deep as a department to have some tough conversations. And I know that Dr. Wright, you're pushing us to continue those tough conversations with your initiative of an anti-racism book club, where we can have small group discussions and grow and learn and push each other. And with a particular emphasis on all being responsible for it and not leaning on our underrepresented minority colleagues to be the ones that have to teach us or to lead us or to help the rest of us be better. We actually had a day in Seattle fairly early on where we wanted to make a commitment as a healthcare community in the Black Lives Matter discussion and protest, led by two of our faculty, that resulted in 8,000 people marching from Harborview, our hospital, to City Hall here in Seattle, and was an extremely powerful moment of coming together as a healthcare community, now not talking about COVID as a public health crisis, but talking about racism as a public health crisis. And so I've been proud of individuals within our department leading that, and that's been a major part of our discussions, including grand rounds and ongoing dialogue within our department. And just briefly touching on COVID, Dr. Clark addressed that nicely, and I'll just emphasize an aspect of responding to the part of the crisis, the surge when we really didn't know what to expect, the early days, when we shut everything down and restructured and didn't know how to manage how to keep our residents and our faculty safe, but also take care of all of our patients. And really, our residents came to us and said, we have an idea of how we can organize the residency program that develops cohorts that are separate from each other to protect the residency program from maybe being completely wiped out by a COVID infection, as well as a well-organized plan for how the residents felt, here's how we can cover the inpatients, here's how we can cover the clinics, and here's how we're going to cover the operating rooms. We're going to keep those firewalled away from each other. These groups are not going to overlap at all. And we had some meetings quickly. I mean, we met, and probably within 5 days, implemented what the residents came to us with. And that's the publication that Dr. Clark put up there that then became actually a leading model for how some other programs manage their faculty and their residents. But we're still in these times. We've got both COVID and racism that we're trying to respond to simultaneously. It's hard work, but it's important work, and we're committed to doing it.
Thank you. We've had a bunch of questions about research. So I'm going to pose two questions about that. Maybe the first to Dr. Droullard, since you're in the lab now. What are some examples of research projects that perhaps you or some of your colleagues have been working on? Why don't we start with that?
Yeah, sure. So I'll first note that once again, we are going to have a dedicated session on this coming up, so stay tuned. My research is in the Surgical Outcomes Research Center here at the University of Washington, which is a multidisciplinary, mostly health services focused research collaborative. We do everything from randomized clinical trials, if you've heard of the CODA trial that recently finished on antibiotics versus surgery for appendicitis. Do everything from that to large scale population health based studies. My interests are in the management of diverticulitis and appendicitis and looking at comparative outcomes in those. We also, I mean, honestly, the number of different things that we do is too many to list. So I'll just say from people in my year, so now going into the second year of research, we have another resident in my same lab who's more interested in foregut surgery and doing projects in that space. We have a resident who's doing basic science, wound healing after burns and traumatic injuries, but also interestingly has an interest in epidemiology of gun violence injuries. Yeah, I think those are a few quick examples to get that question started.
And then Dr. Horvath, another research question. How is the research funded and how does that work logistically?
It's a great question, and just to give some breadth, I just would like Dave, Dr. So, if you could just tell everyone a little bit about the research that you did, because it was very important research.
Yeah, so the research that I ended up doing was a little bit more sort of bench and translational, and it's not as sort of well established as a program in terms of like the SOURCE and T32 fellowships, but we were able to find funding both sort of within our department as well as using some national resources and the DoD, and so my work was in looking at pancreatic cancer immuno-oncology, so taking actual sort of tissue from tumor samples that we were getting from one of our hepatobiliary surgeons in our surgery group and testing various immunotherapeutics within the lab just upstairs from the operating room. So sort of true kind of bedside to bench research. And even though we didn't have a ton of sort of a huge lab here, we have collaborations with huge research institutes like the Fred Hutch Cancer Research Center that provide a significant amount of both expertise as well as the sort of overhead to allow us to do really competitive and high level research. And we were able to get all of that published recently. So that is definitely an area of interest for our particular hepatobiliary surgeons, but others as well. And if you have an interest in that, you should definitely feel free to email or call us or ask us more questions about that during the research talk. And do not feel like that kind of thing is not possible at a surgery program or a surgery residency, or that it's only sort of outcomes-based research that we have access to.
And I'll just say one of the things I've been very impressed by as a faculty, since I came here, I didn't train here, I came here later. A lot of surgery programs focus on one thing in research. They're really well known in this, or they're really well known in bench research. The UW has been incredibly supportive of people with different tracks in research, whether it's health outcomes research, surgical education research. We had a resident a few years ago get a master's in education before going on to pediatric surgery, to the basic science. it's been incredibly supportive of people following a lot of different tracks. And I think that the new emphasis, and then not new emphasis, because the emphasis has been around for a while, but the new track in global health really emphasizes that having a program and a focus in global health, just another example of what the UW is doing.
Thank you very much, Dr. Wright and Dr. So. So going back to the research funding question, we are really fortunate to have many NIH T32 training grants at the University of Washington, a number in the Department of Surgery, but also, so our palliative care T32 is in pulmonary medicine, and one of our residents is actually going to be, is going to be doing surgical palliative care on that NIH T32. And so we also have T32s in pediatric trauma, in vascular basic science and biology research, and in response to inflammation and injury, transplant, and we can just kind of go on and on. I think, and these, I would say that the majority of our residents, the overwhelming majority, are supported with NIH T32s. One of the questions that we often get asked is, what about the shortfall, right? The NIH pays for a certain amount for salary, and who makes up the rest of the salary after that? And the department does. And so you will continue to get paid at your PGY level as you progress through, because the shortfall is covered by the department.
So Dr. So messaged me. He had to run because he had a case to do. He's on our night float rotation right now. It is getting kind of late, so I do want to wrap things up. Dr. Horvath, I want to ask you though, this is a real new world in terms of virtual interviewing. I think Dr. So went through virtual interviews as a fellow. As a fellowship director, I went through virtual interviews on that side. And it is a new world. I think a lot of people have worries about it. How do you see the virtual interview process going? And do you think that's going to change how you select people to do interviews? How's that process going to work?
No, it's a good question, and I think that it's a very exciting time, right? The COVID has really given us opportunities that otherwise may have taken us 20 or 30 years or longer to get to, and so it's again it's a very exciting time. I like to think of it as exciting instead of panic, and when I'm into panic. I think that we're all in the same boat, and I know that you all are. There's a lot of anxiety, on your part. But the good thing is that it's a level playing field, and you're all on the same boat. I think that from the program side of things, I can say the same thing, and we're all trying to. I know that just as your deans and your schools are trying to help you and kind of collect a lot of information and make decisions about how to best do this, we on the program side are also sharing information. We have a National Program Directors Association, and the American College of Surgeons has the Academy of Master Surgical Educators. We have listservs. We're constantly kind of talking with each other and sharing information. How is it all going to, what is it going to look like? I actually don't know. We're actually building the plane at the same time that we're flying it. And that's true for all of us. I do think that people, understanding that we're all in the same boat, people are going to be, we're kind of all having to roll with the punches a little bit. And we're going to, I don't know, be maybe more tolerant of our humanity and mistakes, and we're going to learn as we go. I think at the end of the day, I don't know exactly what this season is going to look like, but I think it's going to be fine, and I think it's going to end well. And we're really writing history right now, and I think that the way that I'm looking at it is, I think that it's an exciting time to embrace and dig in and create something amazing. We are, and I guess I'll end there.
Thank you very much. And I think that's emblematic of the philosophy of this department, that when our goal is to make amazing, and to really come together as a community. And that's true on the academic side. It's true on the social side. It's true as a community. So my parting thoughts is that I think UW Surgery is not just a training program. It's not just a world-class research organization. It's really a community of surgeons, of people that are trying to work together to make it a better place for all of us. So I do want to point out, as I mentioned at the beginning, we are going to have a series of these. This was sort of the broad overview, so we had a lot more slides. In the future, there'll be a lot more conversational. So again, the next one in 2 weeks is going to be just with the residents. And then we'll have ones on research, on wellness, on resident life. So feel free to come to as many of those as you can. Oh, Dr. Horvath has something else to throw in there.
Yeah, we decided today that the residents actually want to jump in sooner rather than later. And so the resident session is going to be next week. And we'll be doing a second resident session in a few weeks, but we're gonna go for it next Thursday, 5:30, same time, same place.
Awesome. And since this is the YouTube era, what is it? Like, subscribe, comment, whatever. So follow us on Twitter, follow us on Instagram, on Facebook. You'll find a lot of us actually are active and happy to answer questions through those different media. So thanks for all of you for joining us. Have a great night.
Hold it. Follow us on Peloton.
That's right. Dr. Wood and I don't know who else is on our Peloton group. Dr. Droullard, are you on Peloton?
Droullard, yes. Droullard is also.
Yeah, well, there it is. Yeah.
Yeah. We have a big UW Surgery Peloton team.
Which is actually kind of embarrassing because Dr. Wood routinely smokes my output scores on Peloton. He's usually top of the leaderboard.
I have my 12-year-old daughter do it.
That's right. All right. Well, have a great night, everyone.